So we studied 30 women with early stage low risk breast cancer. And this was a prospective cohort study in that we identified women who were eligible for us to make alterations, safely make alterations in their radiation plans such that we would not injure, or we would minimize radiation exposure to the lymph nodes that are critical for draining the arm, while ensuring that we adequately radiate the tumor bed. This was 30 women with, again, low-risk breast cancer, early-stage breast cancer. Either they had no lymph nodes that were known to be positive, they would have had a negative sentinel lymph node biopsy, or they had very tiny foci of what we would call micrometastases, a small cluster of tumor cells. But these were women who were not felt to need therapeutic radiation delivered to their armpits. Sometimes, unfortunately, in high-risk women, we have to deliberately irradiate the lymph nodes to ensure that we sterilize the field from any remaining tumor cells. What we found is by using Spec Ct, and Spec Ct is a technology that's been around for quite a while. It essentially merges a CT image, which gives you a great deal of anatomic information, with a gamma camera image, and a gamma camera just picks radioactivity. So when we inject very, very tiny, virtually harmless amounts of radiation into a woman's arm, the lymphatics pick those up and transport those tiny radiation-labeled molecules to the lymph nodes. And those show up on a gamma camera image. But then by taking the gamma camera image and fusing it with a CT scan that gives us anatomic image, now we know exactly where those lymph nodes are located that are critical to preserve lymphatic drainage from the arm. And we took these SPECT CT images and fused them with the images, the CT images that we use for radiation planning. And we found that by doing that, we were able to individually tailor, essentially personalize the fields for each woman such that her tumor and tumor bed were therapeutically treated. They received adequate high doses of radiation, while the lymph nodes that drained their arm were maximally spared. And what we found was we were able to reduce the number of lymph nodes that receive damaging doses of radiation by 55%. It's emerging that the best way to protect women, and that, for that matter, any cancer patient whose lymph nodes are being surgically removed or irradiated, the best way to protect them from developing lymphedema is to minimize the damage to the lymphatic system during cancer treatment, while ensuring that we cure and eliminate the cancer. And so there was a surgical technique called Sentinel lymph node biopsy that has now become standard of care, whereby we significantly reduced the number of lymph nodes that a surgeon removes from the armpit of a woman with breast cancer. And that has been dramatically effective. It's been radically reducing the frequency of lymphedema among patients. Unfortunately, radiation-related damage is a little bit harder to study because we believe that those effects come later, that the scarring and the progressive damage that can be triggered through radiation, sometimes that starts 2, 3, 5 years after the radiation. So again, a little bit harder to study, but we published an article where we showed the _1 risk factor for worsening lymphedema over time was radiation delivered to the lymph nodes. So we can infer from that if we're able to reduce the radiation that we deliver to critical nodes, we should not only reduce women's risk of lymphedema, but also their risk of progressive and severe lymphedema, which is a very important goal. What we would like to do is estimate the lymphedema risk reduction that we can achieve with this technique. And I think it's going to be most effective for those women who do have positive sentinel nodes and do undergo further surgical removal of the what we call the axillary lymph nodes, the lymph nodes in their armpit, because those women their lymphatic system has now been injured. And so any steps we can take to absolutely minimize further injury, I believe, are critical. So ideally, the next step would be a randomized trial where we recruit women who have undergone what's called a completion axillary lymph node dissection, where the surgeon doesn't stop at just a sentinel lymph node biopsy, but removes essentially all the level 1 and 2 nodes from their armpit. Take women in that kind of risk strata for lymphedema and randomize them to get this type of individually tailored, personalized radiation or not. And that way we could much more accurately estimate the benefit achieved with this technique.